Hi, my name is Alexis Harris. I live in Seattle, Washington. On May 2016, I was diagnosed with MDS, myelodysplastic syndrome. I was told I would have 18 to 24 months to live if I didn't start treatment right away. In June of 2016, I immediately started inpatient chemotherapy and then was told right after that that I needed a stem cell transplant. I knew because of my mixed racial heritage, my dad was African American and Filipino, and my mom is white. I knew it was going to be hard to find a live donor, and it was. My twin brother wasn't a match. The two people on the registry declined to move forward with the process. And so my husband and I were told to do option B, which was a mismatched transplant. And so we went into a meeting with a transplant doc that we thought was going to be just to sign paperwork. And it turned out it was Dr. Filippo Milano who had a clinical trial using umbilical cord blood. And he said that it had the potential to save my life. So on September 21st, 2016, I had my stem cell transplant. My kids were 5 and 8 at the time, and I tried to involve them a bit, and they named the 2 bags of cord blood. One's named the female Priscilla, and the other bag was John. And on day 17, I engrafted with Priscilla. Priscilla's amazing stem cells, and I will be celebrating 7 years of my transplant birthday next month. I'm so thankful to Priscilla's family for deciding to donate her umbilical cord blood the day that she was born. She gave me time, the gift of time. She gave me 7 years to celebrate my daughter's 16th birthday this past June, 7 years to celebrate my son's 12th birthday and upcoming 13th birthday. She gave me 7 years to celebrate my 20th wedding anniversary last month. I am so thankful to her, and I really hope that her parents tell her every day that the day she was born, she saved somebody's life, and she is a real superhero. So thank you, Priscilla, and thank you to Priscilla's parents.
Good afternoon, and welcome to the afternoon session. We're going to talk about race and ethnicity and other healthcare disparities and what we all in this room and in the community can do better. So the first talk will be on disparities in access to optimal donors. I'll be talking about non-HLA barriers to transplant, and then we are very lucky that we'll have Dr. Eliane Gluckman joining us by Zoom. On a talk on improving access to transplant for children. And we'll take all questions at the end. We have no disclosures. And so I'd like to start by introducing Dr. Warren Fingroot, who just joined the program at MD Anderson.
Thank you so much, Dr. Ballin, for the introduction and for inviting me to speak, and to the organizers as well. Again, my name is Dr. Warren Fingroot, and the presentation I'll be presenting on, the work that I'll be presenting on today, was all conducted at Memorial Sloan Kettering Cancer Center, where I was a senior research fellow with the cord blood transplantation program. I'm also director of Stem Cell Club, which is a donor recruitment organization I founded in Canada. And I'm an MPH student with the Harvard T.H. Chan School of Public Health. And as Dr. Ballin mentioned, I'm very pleased to announce also that I'm going to be a junior faculty very soon at MD Anderson, starting next month. Thank you. I have no disclosures, and the focus of this presentation is, are there disparities in access to optimal donors by race, ethnicity, and socioeconomic status? And the answer is yes, and I'll show you that through the work and the project that I've done over the past few years, mentored by Dr. Juliette Barker, who's in the audience today, of course. I'll also highlight along the way how cord blood intersects with these disparities and is an important tool to help address them. Now, before I get even into what are the racial ethnic disparities in access to optimal donors, I want to talk about a problem that's relevant here, and that's the classification of patient race ethnicity, the assignment of race ethnicity. And in this project, which involved over 1,700 patients at Sloan Kettering, we compared patient race ethnicity as it's assigned at initial hospital registration to the patient ancestry determined by the BMT staff. And so just to walk you through this in a bit more detail, when a patient walks through the front door of our hospital, they have a conversation, they interact with healthcare staff, and through that interaction, their race ethnicity is recorded and it becomes part of the chart. And separately, at time of allograft evaluation, the transplant staff perform a detailed kinship history with all patients to ask patients where are they from, where are their ancestors from on their mother's and father's side, and do they identify as Black and or Hispanic, and based on that information, their ancestry is classified. And with this project, we compared the race ethnicity as from initial registration to the ancestry determined through a detailed kinship history. And you can see in the graph on the right, there are marked differences, inaccuracies, inconsistencies in the race ethnicity versus ancestry assignment, where, for example, of almost 1,300 patients that were initially recorded as white non-Hispanic, 11% had non-European ancestry. And furthermore, of almost 100 patients whose race ethnicity was initially recorded as unknown or refused to answer, or as this nebulous other category, all of them provided their ancestry on detailed ancestral history, of whom over 50% had non-European ancestry. And so through this more detailed recording process, the detailed ancestral evaluation increased the proportion of Hispanic, of African, of Asian ancestry patients. And these inaccuracies in race, ethnicity, ancestry assignment are important to correct and to address because they interfere with alternative donor searches, correlative laboratory science, reporting to funding agencies, and ultimately mitigation of healthcare disparities. I want to outline my first project, actually, that I conducted at MSK, again under the careful mentorship of Dr. Juliette Barker, which outlined disparities in access to unrelated donors over a 6-year period as a 601 patient analysis. And first we found, as expected, that of transplanted patients, non-European patients received half the proportion of fully matched unrelated donors compared to those of European ancestry. But furthermore, we went a step further in this analysis, and we looked at not only who was receiving a matched unrelated donor, but among those patients who did receive a matched unrelated donor, who received an optimal donor, i.e. a donor that's less than or equal to age 35 years. And we found that non-Europeans who received matched unrelated donor transplants were less likely to receive optimal or younger unrelated donors. And if you can see in the graph, we mapped this over time, and this is not improving over time. You can see the disparity where blue is European and orange non-European ancestry patients, and even as time is progressing, that gap's actually widening as things are improving for the European ancestry patients, but not for the non-Europeans with respect to finding a younger unrelated donor for them. We also, in the same analysis, examined haploidentical and cord blood graft recipients. We found that non-European ancestry patients were more likely to have an older haploidentical donor and were more likely to receive a cord blood graft where at least one unit was either highly mismatched and or had a low CD34 positive dose of less than 1.5 times 10 to the 5 per kilogram. And so across the board, non-European ancestry patients were less likely to receive optimal donors. In this separate analysis, we also found disparities in time to transplant. And we examined a cohort of 313 patients, transplant recipients, who were adults with acute myeloid leukemia. And we examined the time from transplant indication, that's the time that they were diagnosed with AML requiring transplantation, through to the time that they received their transplantation. And we analyzed that by ancestry and by stem cell source. And the first finding in this analysis is that the non-European patients were less likely to be transplanted if they were older. So you can see in the data in the box on the left that the median age of non-European ancestry patients was 49 years compared to 60 years for Europeans. And that means that the older non-European patients were not making it to transplant in our analysis. But furthermore, we found that the time to transplant for non-Europeans was delayed if they received an unrelated or haplo donor, and they had fast time to transplants if they received a sibling or cord blood graft. And I want to orient you to the graph on the right. So you can see, for example, on the left you see the non-Europeans, on the right you see on the left you see the Europeans, on the right you see non-Europeans. The axis is the time from allograft indication to allograft, and then you see in green sibling transplants, in light blue 8 of 8 unrelated donors, in red cord blood, purple is haplo, and dark blue is mismatched unrelated donors. And you can see that with respect to the green and red, that's sibling and cord blood, both groups, Europeans and non-Europeans, proceed quickly to transplant. But then when you look at the light blue, the 8 of 8 unrelated donors, Europeans proceed relatively quickly to transplant, but non-Europeans face marked delays. And then haplos and mismatch unrelated donors are delayed in both groups. In this additional analysis that we are conducting right now, our manuscripts currently in development, we examined the unavailability of a large cohort of donors that were requested for 455 patients, requested for confirmatory typing and workup. And just to walk you through this complicated diagram, this flow chart, you can see that of the 3,800 approximately donors that were requested, the majority were requested first for confirmatory typing and then for workup. A small proportion were requested for simultaneous confirmatory typing and workup. Generally, these donors were requested for patients who needed transplant urgently. And you can see in blue those who continued along, and in red those who fell off because they were unavailable. And you can see that a large portion of patients, a large portion of donors were unavailable even for the first step for confirmatory typing at initial request. A smaller proportion, but still a large number, were not available at time of workup. And then there were even patients who cleared workup, who were available for workup and completed workup, and then afterwards became unavailable for donation, sort of backing out right before the transplant. And overall, across this cohort, less than 50% of donors requested were available for the patients who needed them. And zooming in by ancestry, comparing by ancestry, there were marked disparities in donor availability, both at confirmatory typing on the left and workup on the right. And in this chart, the x-axis shows over time. The y-axis is those who agreed to proceed with either confirmatory typing or workup. And again, you can see that this is not markedly improving over time. And the donors for non-European, compared to European patients, are more likely to be unavailable. It's not improving. The worst unrelated donor unavailability was for African and for non-Black Hispanic patients. And you can see that in this graph over here, where the y-axis is the proportion who are available for donation overall. And the purple is showing that there's less than 50% of requested unrelated donors were available overall. The blue group, Europeans, showing just over 50%, but then orange, just less than 40% of non-Europeans were available overall. Non-European donors for non-European patients were available overall. And then if you look at the box in the inset, zooming in on the African ancestry patients, less than a third of donors that were requested for these patients were available. For non-Black Hispanic, less than 40%. I want to highlight a number of potential solutions to this donor unavailability problem, and I'll walk through them. The first would be to eliminate all presence of donor discrimination, and I'll walk you through that in a moment in the next slide. It will be important to collaborate with advocates to address racial disparities in representation on donor pools, stem cell donor pools, and also to work closely with registries and advocates to reduce donor attrition, which is a significant problem and contributes to the dropout across the donation journey, the donor journey. It will be important to speed donor identification, and this will include simultaneous activation for CT and workup of multiple unrelated donors. And this is something that registries should permit and that transplant centers should request. And furthermore, it's important to use unrelated donor search prognosis tools, such as that developed by Eric Davis et al. From MSK, to facilitate rapid triage of alternative donors, particularly if there's a low chance of an unrelated donor, a fully matched unrelated donor being available. This may require, and will likely require, reforming insurance reimbursement, and most importantly, expanded access to alternative donor transplantation is warranted. And I'll highlight cord blood in particular, but I also want to make a comment about mismatch unrelated donors with post-transplant cyclophosphamide, which we've talked about early this morning. Through expansion of mismatch unrelated donors with post-transplant cyclophosphamide, this is an additional option to extend access to alternative donors for patients. However, it also depends on how low you're willing to go with respect to the match grade. So at Sloan Kettering, for example, we routinely transplant patients who are 7 of 8, 6 of 8, but depending on how low you're willing to go, it's still unknown. There's very limited data to guide what's acceptable and what's standard of care in that space. Now I want to highlight just a few. I don't have time to go through all of these in detail, so I just want to highlight those in blue additionally to go through some of these solutions in more detail. Now, I mentioned that while it's important, an important avenue to address disparities across donor pools is to recruit additional donors. One of the problems that needs to be addressed is donor discrimination. And I highlight here this recently published hematopoietic progenitor cell donor history questionnaire designed to screen for infectious disease risk factors, authored by a multi-institutional task force across transplantation, cited by the World Bone Marrow Transplant Association Standing Committee, recently published in the Lancet Hematology Review. And I want to highlight some of these questions from this questionnaire. For example, have you ever had sex with anyone who was born in or lived in Africa? Have you ever been to Africa? These questions are designed to screen for HIV risk, but are totally unacceptable to screen for HIV in the current era. And furthermore, if you look at the questions below, which are biased against donors from underserved populations, in the past 12 months, have you been in juvenile detention? Have you been in jail? Again, they're screening for infectious disease risk factors, but we know that patients from underserved populations, patients from marginalized populations are more likely to have troubles with the law. And again, I think that these questions, when you show them or ask them to donors from these underserved groups, I think that there's definitely they exacerbate historic mistrust between populations. I'm director of Stem Cell Club, a donor recruitment organization in Canada. We conducted focus groups with members of the Black community to help understand what the barriers are with respect to donation. And I want to share a quote from one of the focus group participants. Quote, "Seeing in our Black community how we're treated or disregarded in the medical fields, we may not be willing to even consider donating stem cells." And questions like these do not help that. I also will comment that there's no value to asking these questions at the time of initial registration, and there's little value or limited value of asking them compared to a more detailed workup, the history, social history, travel history, et cetera, that's performed by the transplant team at time of workup of the donor. And so the solution here is to prioritize health equity alongside donation safety. I also want to comment on work that we've done to collaborate with advocates to address disparities. And here's a snapshot of Stem Cell Club's Black Donors Save Lives campaign, led by Sylvia Okonefa, a mentee of mine. And together with advocates from the Black community, Stem Cell Club put together an array of diverse multimedia resources shown here. And then we disseminated those resources in collaboration with partner groups from the Black community, Black medical associations, student associations, community groups. The work was amplified by media, and in focus groups with members of the Black community was shown to reduce barriers to donation. And this is just an example of work that needs to proceed in collaboration with advocates from the community that we seek to engage with to address disparities. An important solution that I want to highlight is to advance and to promote and to extend access to cord blood transplantation. And I want to highlight data from MSK, which highlights the outstanding value of cord blood transplantation, the outstanding survival in adults with hematologic malignancies after intermediate intensity double cord blood transplantation. And this is data also that Dr. Barker shared this morning. And you can see in this cohort of 25 patients, recent patients who are young and middle-aged adults who received double unit cord blood transplants with a HLA match of 4 to 5 out of 8. You can see that the 1-year overall survival is 96%, the 1-year progression-free survival 87%, and this was with a median follow-up of 17 months. Graft failure 0%, 1-year transplant-related mortality 0%. And these data show that cord blood is a critically important alternative stem cell source, especially to extend access. I've talked so far in my presentation about racial and ethnic disparities, and I want to shift gears now and talk about socioeconomic status and socioeconomic status disparities. And I want to highlight that while it's known that there's an intersectionality between race, ethnicity, and socioeconomic status, patients' socioeconomic status classifications are not standardized, and this is a limitation with respect to studying disparities in the field. And I want to highlight especially that annual family income data is generally not available for our patient populations. At least it's not connected in a way to the BMT databases and so on that permits research. And so for this study that we conducted at MSK of 425 allograft recipients, we examined a number of surrogates of low socioeconomic status. We examined neighborhood poverty, which we classified as low socioeconomic status if the area deprivation index was greater than or equal to 60. We classified patients as having low socioeconomic status if they had Medicaid as their primary insurance at the time of BMT, or if they received financial support for cost of living or medical expenses. And you can see in this flow diagram, the Sankey diagram on the right, that with respect to neighborhood poverty, 5% of patients had low socioeconomic status. With respect to their insurance, 7.5% of patients in the cohort had Medicaid. 15% received financial support for medical expenses, and 20% received financial support for cost of living expenses. But overall, different socioeconomic status surrogates describe different subsets of patients. And this is important because it's difficult to help or to identify, if you can't even identify easily who is most vulnerable, who is most at risk for financial hardship, then it's difficult to intervene and address. And therefore, inaccurate socioeconomic status classifications interfere with the mitigation of healthcare disparities. In the same analysis, we found, importantly, an intersectionality between ancestry, socioeconomic status, and donor type, where we found that in this cohort of 425 patients, the non-European patients who received HLA disparate grafts, that's cord blood, haploidentical, or mismatched unrelated donor grafts, they were most likely to have at least one or at least two surrogates of low socioeconomic status. And these data emphasize most strongly that the most vulnerable patients, non-Europeans of low socioeconomic status, received the most complex HLA disparate transplants requiring the highest level of care. I've talked about race, ethnicity, I've talked about socioeconomic status, and I want to overlay gender and gender disparities now at this time with this analysis that's currently underway with the manuscript in prep related to the disparities that female patients face with respect to HLA antibody burden. And in this 672 patient analysis that we're conducting right now and that we're writing up for publication, we found that 90 patients were both broadly and highly sensitized to HLA. So specifically, we classify these 672 patients according to who had a positive HLA antibody screen, and among those who had a positive HLA antibody screen, how many antibodies did they have, and what was the intensity, the highest MFI, mean fluorescent intensity of the antibody. And based on that, we classified them as broadly, highly, or broadly and highly sensitized to HLA. And we found that of 90 patients, broadly and highly sensitized, the majority were multiparous females. And you can see that in the graph, the dark green. And this is very important because it's a limitation for haploidentical transplant. And it's an additional access barrier, especially for non-European ancestry women who, on the one hand, are less likely to have a matched unrelated donor available to them, and on the other hand, will be facing these additional barriers to receive haploidentical transplantation. I want to summarize now and share the key findings of the presentation. First of all, prospective data collection are needed. First of all, as I mentioned at the beginning of my presentation, for race, ethnicity, and ancestry data, but also for the collection of data related to the social determinants of health. Without these data, it's difficult to identify patients who are most at risk and to characterize and then address the disparities and to design interventions to address them. The best stem cell source is the source with the best available graft characteristics, which facilitates transplant in the time required. And this needs to consider all stem cell sources, including cord blood. With respect to the high unrelated donor availability that we described, there are multiple solutions that need to be pursued concurrently, particularly the simultaneous activation of multiple donors for workup, the triage of donors to alternative donor allografts rapidly, the development of strategies to address attrition, and more. The extension of bone marrow transplant to underserved patients is contingent upon addressing financial hardship, and there's a need to consider the intersectionality of race, ethnicity, and ancestry, and socioeconomic status. There's an additional burden that I showed with the data here on multiparous females with respect to HLA sensitization that needs to be addressed. And finally, there's a need to collaborate with advocates from diverse communities to minimize donor discrimination and address disparities. Thank you. I want to introduce Dr. Ballin as well for the next talk.
Thank you, Warren. That was excellent. And like I said, we are going to do questions at the end. So I am going to talk about access to transplant and what we can improve and focus on non-HLA barriers to transplant. We'll talk about some economic and healthcare disparity that will focus mostly on the US, but the principles may apply elsewhere. Look at cord blood outcome data by race and ethnicity. We'll talk about something called a social vulnerability index and what we in this room can all do to move us forward in future directions. So just for fun, we'll take a poll of what people think is the richest county in the US. We've got Fairfax County in Virginia, just outside of DC, Fairfield County in Connecticut, outside of New York, Loudoun County, west of Fairfax in Virginia, and Marin County with the Redwoods in California. So we'll just, by show of hands, who thinks it's Fairfax? Fairfield? Loudoun? Or Marin? This is Loudoun County, Virginia. Nice house, nice little house here. This is horse country west of DC. median income about $200,000. What is the poorest county in the U.S.? And this has changed actually over the past year. Holmes County in Mississippi, Grayson County in Appalachia, Virginia, Buffalo County in South Dakota, and McDowell County in West Virginia. So who thinks it's Holmes? Grayson, Buffalo, and McDowell. So it's Buffalo County, South Dakota, with about an 80% Native American population, median income $12,000. So we know we have a lot of problems in this country, but just to bring it back to this meeting, what is the difference in access to transplant in the richest and poorest areas in the U.S.? And this study was undertaken to bring awareness to healthcare disparity and to look at some metrics to track areas of poor healthcare access. We know that less than 50% of adult patients with high-risk AML actually receive a transplant. And we selected Virginia because we have access to data there. It has urban and rural areas and wealthy and poor areas. This initial study did not look at transplant outcomes, but just looks at who gets to a transplant. We know that it's difficult for patients to access a transplant factor. This may be due to physician availability, center factors, and of course patient factors related to travel and other costs. This may be more difficult for older patients, and it may be more difficult for patients that are caring for multiple generations. We compared the incidence of AML with CIBMTR data on the number of transplants performed, and we discovered the difference in transplant access based on geographic region, race, ethnicity, and socioeconomic factors. And we observed major differences in access to care based on geographic regions. So this study was done in collaboration with CIBMTR and NMDP and published by one of our fellows, Joey Mock. But we can see in this green area in north, oops, I did the bad thing, but we can see here, this is looking at Virginia. So this area here is area near DC, which has about 25% of access to transplant and less than 25% African American population. This area here in southeastern Virginia includes Richmond, the capital, has only a 15% rate of transplant access for AML and has a much larger African American population, greater than 25%. We looked at something called a social vulnerability index, and as Warren mentioned, there are many parameters to look at social determinants of health. This one was developed by the CDC to identify at-risk populations during natural disasters, including hurricanes in Florida, and currently also used for COVID. And it includes information on socioeconomic status, household composition and disability, minority status and language, housing and transplantation, and in the last few years now we've been using it in cancer studies. And in this study, we showed that a higher social vulnerability index is associated with a decreased rate of getting to transplant for AML. And this is what the social vulnerability index includes. So you can see there's socioeconomic status, looking at poverty, unemployment, education, and health insurance. There are household characteristics, looking at if there are elderly or children in the home, a civilian with a disability, single-parent households, and whether there's English language proficiency, looking at racial and ethnic minority status, and also looking at housing and type of transportation, if there's crowding, if they live in a mobile home, if there is no vehicle. All those things can filter into this social vulnerability index. So conclusions from this Virginia transplant access study, we see a high variability in transplant access. Communities with a higher African American population have poorer access to transplant. And we looked at a higher education level, private insurance, and although I didn't show this data, if you're married to any gender or have a stable partner, that is associated with higher access to transplant. Communities with a high social vulnerability index have poorer access to transplant. And so this social vulnerability index may be a useful tool to identify communities in need of more resources. And while the study is not perfect, I think we all agree that there is much room for improvement. More recently, we've looked at the social vulnerability access and transplant outcomes. So this is a study on multiple myeloma auto transplant, a little bit outside our level of what we're talking about here, but just to show that in addition to transplant access, this index also affects transplant outcomes. This was a study that one of our residents presented at TCT, and we see that if you have a higher social vulnerability index on the red line, your chance of getting to transplant, your chance of surviving at 5 years is much less. So social vulnerability affects access to transplant and outcomes after transplant. So we're all interested in cord blood. How can cord blood help with access to transplant care? Well, we know, of course, it's a readily available stem cell source. I'll be presenting some data from the CIBMTR, which shows comparable survival to Black African American patients who receive either cord blood or haplotransplant. An NMDP analysis has shown comparable survival after umbilical cord blood transplants for adults of different race and ethnicities. And I think we are also some encouraging data on improvement in survival in recent years. So this is a study published by Scott Solomon looking at data from the CIBMTR, looking at 249 haplo and 118 umbilical cord blood transplants done in Black African American patients. Between the years of 2008 and 2016, all the patients had hematologic malignancy. Graft versus host disease and transplant-related mortality was higher in cord blood, but overall survival, disease-free survival, and relapse are comparable. And I think the message from the study is that either haploidentical transplant or umbilical cord blood transplant expands access. And this is the data from the study. As you can see on the left, we're looking at overall survival, and on the right, progression-free survival. Both of these curves are similar statistically, showing that haplo and cord blood had comparable survival outcomes in the Black population. And this is data from Be the Match, so provided by Be the Match, looking at cord blood use. And so this is just looking at unrelated transplants, not haplo. I think the key metric here is in the middle. These are Black recipients. 20% are receiving umbilical cord blood transplant. The other 80%, other types, would be either fully matched or mismatched unrelated donors. So that cord blood is still a very important graft source, particularly for African American patients. And next, what about transplant outcomes after cord blood? So does race and ethnicity impact outcomes after umbilical cord blood transplant in the modern era? We had done an earlier study with the CIBMTR, and this is a more modern study done in collaboration with Will Saber and the group from CIBMTR. And we compared outcomes for cord blood transplant among different race and ethnicities, just in the US, for leukemia. And what we found is that outcomes after umbilical cord blood transplant have improved for all racial and ethnic groups, although the improvement has been less for Latinx patients, and the overall survival is unfortunately lower for Latinx adult patients. We found that overall survival in children was comparable among racial and ethnic groups, although grade 3 to 4 acute GVH was higher in Black children. So this is the data from this study. So this is looking at adult patients. The lower line is the Latinx patients that, as I mentioned, did not have as good overall survival after adult cord blood transplant for leukemia. But when we look...
This graph looks at the adjusted probability overall survival for adult patients and illustrating the improvement of survival over time. The two blue lines represent the more modern cohort.
Oh, okay. Well, thank you in the back. We're good? Oh, and now we want to move back, which is also hard to do. How do we move? Okay. Great. There was nothing.
Yeah, continue on.
Okay, is it, are we all set?
Yeah, go
Yeah,
ahead.
okay,
Stand
all right.
by.
All right, I think we're all good. Thank you. So we're going to look at this data. So this is adults, and showing that the Latinx patients unfortunately had poorer survival. This is the slide we got caught on. This is overall survival for adults by different time points. And as we can see, we are improving over time. This is the most recent cohort, so it has a shorter follow-up. But overall survival for cord blood transplants is improving over time, thanks to some of the advances that we heard about this morning. Okay, thank you. And in pediatrics, we see that overall survival is similar among these four racial and ethnic groups. But when we look at acute GVH, grades 3 to 4, that is higher in Black children for reasons that we are still looking into. There are some differences in metabolism of tacrolimus in Black patients. Whether this is the answer to this issue or not, we don't know. Next, I want to talk about HLA today. So just out of curiosity, how many people in the room use HLA today? Okay, well, so this is good that we're all here. So HLA today is HLA typing. It's done by cheek swab at a local community oncologist. Does not need to be done at a transplant center. Thank goodness, Be the Match assumes the cost. So for those of us in transplant centers, this counts as one of the 2 required HLA typing. So you can also save some money. The HLA today includes both the patient and first-degree relatives. The typing report is sent to the local oncologist, so it is important to be communicating with your referring doctors because if they don't put your name on it, they may get the typing report and have difficulty interpreting. They can send to as many transplant centers as they wish. The patient is not making any commitment to go to a specific transplant center. But it allows the patients to be typed at the time of diagnosis of leukemia. Again, this would be for centers that do leukemia induction but don't do transplant. So the typing is being done while the patient is getting their leukemia induction, maybe 3 or 4 weeks before they actually get to a transplant center, so it can really speed up the time to transplant. As I said, the local oncologist can designate whatever transplant centers they want to go to. It is not a commitment to a specific center. HLA today has typed over 1,800 patients. 46% of these patients are non-white patients. We are eagerly awaiting some outcome data. We don't have that yet, but I encourage you, if you're not using HLA today, to consider doing so. And then I want to mention patient financial assistance from the NMDP. So NMDP provides a large amount of financial assistance, $6 million and over 2,000 grants. And our center, I know, uses this a lot. Just as of a show of hands, who else is using NMDP financial assistance? Great. And that is for search and procurement costs, temporary housing, co-pays for prescription and clinic visits, parking and gas, caregiving expenses, and travels to participate in a clinical trial. And then I also want to mention community academic partnerships. So instead of asking the patient and their family to travel to a transplant center, which can really disrupt the family, especially if multiple generations are being cared for, can we provide better care in the patient's local community? And I think COVID has taught us that there's a lot more that we can do with televisits and other forms of communication. This study was presented by Goya Abel at ASH last year and is a randomized study of a shared care model versus standard transplant center care, not necessarily focused on cord blood, but just on transplant in general. And so they looked at two groups. One is sort of their standard group, which requires the patient to live in Boston for 3 months, or to share post-transplant care with community oncology groups in New England, and the patient returns home, with the majority of care being done by their local oncologist, but televisits by the transplant center. They found that outcomes were similar in the two groups. As you might expect, quality of life and patient satisfaction was much improved in the shared care model. And so I think one of the things that we want to consider is how we can bring care closer to the patient rather than asking the patient and their family to assume the travel burden. So in conclusion, this work has focused on the US and the US healthcare system, but some of these principles do apply worldwide. We do see a large disparity in access to transplant. We know that cord blood is a readily available stem cell source with comparable survival among different racial and ethnic groups in adults. Black patients have shown comparable survival between cord blood and haplo. And then newer programs such as HLA Today, community partnerships, and NMDP assistance may all help us improve access. So thanks very much. And now it's my pleasure to introduce by Zoom Dr. Eliane Gluckman. Her talk is pre-recorded, but she will be on the Zoom for the Q&A.
The title of my talk is Improving Access of Hematopoietic Stem Cell Transplantation in Children. I have no conflict of interest to declare. Allo stem cell transplant is a highly complex, costly procedure for patients with hematologic, genetic, and immunological disease. However, it is still associated with significant morbidity and mortality, requiring advanced care consisting of significant infrastructure and a network of specialists from all fields of medicine. In recent decades, a worldwide increase in the use of transplant has been seen due to better donor availability, optimization of indication, and rapid evolution of molecular techniques, use of novel reduced intensity conditioning regimens, improvements in early and late outcome due to better supportive care. So what are the factors associated to access and outcome of allotransplant? There are many and very complex and must be fulfilled completely. They are the donor type and stem cell source availability, unrelated adult cord blood and related haploidentical donors. Patients' demographic is also important concerning age, gender, and race. Social problem, geographical distance, patient family attitude, availability of caregivers, provider, physician referral and indication. Healthcare system is also very important to consider. Transplant rate, transplant center density, infrastructure and complexity, public and private care, establishing new programs, national and international regulation. And of course, economics is very important, especially for low and medium income countries. And it means that you have to consider the country of origin, the gross national income per capita, health expenditure per capita, human development index. So to start this lecture, I will first show you what is the state of the art of pediatric cord blood transplant in Europe and how you can achieve that in low and medium intermediate countries. The Eurocord registry has collected cord blood transplant, and this is the 5-year overall survival of unrelated cord blood transplant in children with non-malignant disease. And you see that the survival range from 55% to 75%. The most frequent indications are inborn error of metabolism, immune deficiency, and bone marrow failure syndrome. And if we look at more recent results, which have been published recently in Blood Advance, this is a prospective trial in children with non-malignant disorder, transplanted from 2009 and 2020. They received one mismatch or matched transplant with a myeloablative conditioning consisting of busulfan, cyclophosphamide, and fludarabine, and no ATG. 55 patients were analyzed, and you see that the survival is excellent, much better than what we have in our registry. It's a 91% 2-year survival. Full chimerism was achieved for all but one patient. Acute GVH was low, 16%, with no chronic GVH. The metabolic defect was corrected in all patients. Prompt lymphocyte reconstitution was observed as shown by the reconstitution of CD3, CD4, CD8, CD19. So what does it mean? Omission of ATG leads to excellent overall survival in MAC cord blood transplant for young children. If we look at malignant disease, the 4-year overall survival ranged from 49% to 58%. The main indications are ALL, followed by AML and MDS, and the survival is around 50%. And if we look at the main prognosis factor, in fact, the status of the disease is very important. In ALL, the survival is 59% in first CR compared to 21% in advanced disease. And for AML, the same is observed with 63% survival in first CR compared to 24% in advanced disease. But these results has been challenged by a recent publication from the Manchester group showing that improvement can be achieved. And this is published in Blood Advance recently. This group compared 112 cord blood transplant with 225 related or unrelated transplanted from 2014 to 2021. The diagnosis was high-risk relapse or refractory AML or MDS. And the question was, UCBT without serotherapy may be the optimal transplant option for children with myeloid malignancy. And these are the results. The event-free survival is dependent on the status of the disease. The patients transplanted in remission are better than refractory disease, but you can see that even with refractory disease, the survival is 50%, which is an improvement compared to what we have in the registry. Transplant-related mortality, when comparing that with other source of cells, was slightly worse in cord blood transplant, but the major difference was the difference in relapse. Patients transplanted with cord blood had less relapse than with other source of stem cell, and this was true for MRD positive or negative patients. So UCBT without serotherapy may be the optimal transplant option for children with myeloid malignancy. 2-year event-free survival was 80% for CR1 and 61% for CR2. Less relapse in cord blood transplant, particularly in MRD positive patients. We performed a study entitled Unsupervised Clustering Analysis of Pediatric ALL and AML to elucidate treatment practice that promotes sustained relapse-free survival. And this is a collaborative study between Eurocord and Nolan, and an abstract has been submitted to ASH. The objective of this study was to characterize and perform a critical appraisal of commonly implemented clinical strategy to guide further interrogation of the effects of specific HLA match combination on post-UCBT outcomes, to investigate the effect of ATG, to investigate the effect of TBI. And we analyzed 735 patients with ALL, 271 patients with AML receiving a single unmanipulated cord blood transplant between 2004 and 2022. What did we see? We saw that the use of ATG, again, ATG comes back, the use of ATG decreased long-term survival both in ALL and EML. So this means that ATG usage may be associated with relapse in the late post-transplant setting. Most studies of ATG do not follow patients for this length of time, so effect may have been previously missed. T-cell reconstitution correlates positively with EFS and is disrupted by ATG. The second thing is when we're looking specifically in the role of HLA in AML. We did not find anything for ALL. And if we look at the blue, which is the relapse-free survival, you see that the best results are obtained in match transplant, 8-8. But if you have one mismatch HLA-C, the number of relapse increase. And this effect is abrogated when you see two mismatch, C and A or C and B, which abrogates the effect of HLA-C mismatch. So what does it mean? 7 of 8 matched graft with a single mismatch at HLA-C result in significantly increased relapse risk in AML, but not ALL. It agrees with existing findings, showing that NK cell reconstitution predicts outcome in AML, but not ALL. Introduction of a second mismatch at A or B reduce this risk, perhaps explained by disrupted interaction with KIR-free DL1. TBI is also an important factor in the analysis, and it was found in ALL, and it showed that TBI improves survival both in HLA match or mismatch transplant. So TBI usage consistently produces equivalent or superior relapse-free survival in ALL, regardless of HLA matching. It protects against relapse mortality in the early post-transplant setting. It has a beneficial effect sustained to more than 10 years post-transplant. So, in patient graft pairing, when non-relapse mortality risk is low, ATG omission may increase the odds of achieving sustained relapse-free survival in pediatric ALL and AML. HLA-C mismatch are relapse promoting in pediatric AML but do not appear to play a role in pediatric ALL. The incorporation of TBI into pediatric ALL increase odds of achieving long-term relapse-free survival regardless of the HLA match status. So how can we translate that to low and middle income countries? The best example is to look at transplant for sickle cell anemia, because it's a genetic disorder which is observed in all countries because of the diffusion of this genetic disorder with migration of population. The current treatments include drug treatment and allogeneic transplant. The drug treatment has improved the symptom but does not cure the disease. But the use of hydroxyurea has been very important to improve survival in these patients. Allogeneic transplant is the only curative treatment at this stage. Future treatments are under investigation, and it includes ex vivo gene therapy or in vivo gene therapy. So what are the results of transplant for sickle cell disease? And this is a survey of 1,000 patients, which was published in Blood in 2017, that I will summarize. It shows that event-free survival was 93% in children and 81% in adults. When looking at the cell source, bone marrow and cord blood gave the same result. Peripheral blood was worse. And one of the main findings is that age is a very important prognosis factor. Patients, children had a better survival than adults. It was seen in event-free survival, and also the number of graft failure was increased in adults, probably because of the number immunization with the transfusion. Alternative donor hematopoietic stem cell transplant, the number is really limited, and this is preliminary results comparing unrelated adult, haplo post-side, haplo T-depleted. It shows survival at 80%, but these results have to be confirmed in larger number of patients. So HLA identical sibling transplant is an established treatment for SCD. It should be performed as early as possible. Related haplo, unrelated cord blood, gene therapy, and gene editing trials are ongoing with promising results. Mixed chimeras is common, and its management is key to optimal outcomes. This is the survey of the number of patients transplanted for hemoglobinopathies in Europe. And you see that in the green curve, the number of children with sickle cell disease and the number of adults, red curve, are increasing with time, while the number of thalassaemic patients, adult and children, are decreasing. We performed a study to see what was to look at what was the probability of finding a match unrelated donor for patients, because we know that not everybody has an HLA identical sibling, so we have to look for alternative donor. So this is a study on HLA haplotype frequencies and diversity in patients with hemoglobinopathies, which has been recently published in EGM. So the rationale, the genetic diversity of the human leukocyte antigen HLA system was shaped by evolutionary constraints exerted by environmental factors. Analyzing HLA diversity may allow understanding underlying pathway and offer useful tools in transplant setting. So the objective of this study was to investigate the HLA haplotype diversity in patients with sickle cell disease or beta thal received a transplant, and to compare frequent HLA haplotypes to African and European haplotypes from the 1,000 Genomes Project. So these are the results for sickle cell disease. We identified the 8 more frequent haplotypes. They are very different from the Caucasian haplotypes. Compared to the African haplotypes, they are found, except the second one, which was higher in the sickle cell registry. But if you look at the number, we found 55 patients, 10% of the population, who had this frequent haplotype, showing the extreme diversity of the haplotypes for patients of African origin. It was different for beta thal, where the haplotypes we found were more frequent in the Caucasian registry, and so the probability to find a match unrelated donor for transplant for beta thalassemia is higher than for sickle cell disease. So due to the extreme diversity of HLA haplotypes in sickle cell disease, the probability to find an HLA match unrelated donor is limited. In beta thal, frequent HLA haplotypes are closer to the Caucasian population and therefore similar to the majority of donors available in unrelated donor registry and umbilical cord blood banks. For patients of African origin, it is important to increase the recruitment of donors of African descent in registries and cord blood banks. So what happened with transplant in Africa for sickle cell disease? First, the number of patients all over the world is increasing. And you see it is present in most of the countries, but it is really very important in Africa and in India. So what is the possibility to do the treatment for these patients? You see that the number of sickle cell disease treatment centers is very limited. And we have only two or three countries who have several treatment centers. It's Nigeria, Ghana, Tanzania, Kenya. And if we look at the number of transplant centers, it's only two. Nigeria, South Africa, and now Tanzania is starting a new program. So what happens? All these young children affected by sickle cell disease are asking us, can we get the cure, and what can we do for them? So it was I have to thank really very much Dr. Stella Malongahe from Tanzania, who gave me the opportunity to present here results from the first experience of transplant in Tanzania. So the challenge, I already said, are very high. It's a high-cost procedure. There are family issues, donor issues, and patient issues which have to be solved. And this means that you need a lot of interaction with hospital leadership, finance, and partnership with established transplant center. And then you have to look at hospital infrastructure, diagnosis laboratory service, personal training, pharmacy, blood products, stem cell processing. All that has to be solved. So this program started in 2018 in collaboration with an Italian center. And from 2019 to 2021, there were expertise advice, training, renovation of the unit, upgrading of supporting service, procurement of medical device, drugs, and consumables, and even with the corona pandemic. In 2012, there was on-site Italian training visits, virtual and clinical training in Italy, finalizing procurement activity, patient eligibility screening. And at the end, in 2023, the first transplants were performed in Dodoma. So the team consisted of 3 doctors, 10 nurses, 4 medical attendants, 2 pharmacists, 2 lab scientists. And there was a training at the beginning, and it was also supported by the sickle cell clinic, which treat 450 patients treated for sickle cell disease. They had the protocol. It was a standard protocol with a condition, myeloablative conditioning with Bussai ATG, with cyclosporin, methotrexate, bone marrow harvest in infusion. All patients engrafted at an average of 22 days. Transfusion was irradiated and leukofiltered. The discharge was on day 50, and they had the infectious disease prophylaxis. So all patients achieved engraftment. Only one patient developed a grade 2 skin GVH, no chronic GVH, no transplant related mortality, no incidence of CMV reactivation. So it was a complete success. And this was a success because of the important government role, because there was the availability of Tanzania sickle cell disease guideline, scaling up sickle cell disease service to primary health care, availability of essential medicine in referral hospital, sickle cell disease included in training package, contribution to funding of BMT centers, willingness to cover costs for first 20 patients candidates funds set to for sustainability purpose. So these are these young, beautiful, cured patients with sickle cell disease, and they were transplanted in Africa. So it means that it is possible to do transplant in Africa. So what are the questions? Should Africa prioritize comprehensive care of research for cure? Can curative therapies be provided in Africa? Where? Who? What is the cost? Resources are limited. Why don't you focus on interventions that will help many? Why is equal access to new and curative therapy important in Africa? And we have two options, transplant, gene therapy. And if transplant is immediately available, gene therapy needs more research. So for transplant, one question is what is the best donor source for transplant? Matched sibling, mud, haplo, cord blood. But we know that matched siblings are, it's only 25% of the population. For alternative donors, it's more difficult, and so there is a choice to make. So why cord blood is relevant to pediatric transplant? It has advantage, reduced time to transplant, increased donor pool, more tolerant with HLA mismatch, less disease relapse after cord blood transplant for malignant disease. After engraftment, cord blood recipients are more likely to have full donor chimeras than bone marrow transplant. Low incidence of chronic GVH. Change from cord blood to haplo is likely to be associated with adverse outcome in children. In conclusion, HLA identical sibling transplant is feasible and should be developed. For patients without a matched sibling, what is the best alternative? Matched unrelated donor finding is very low. Mismatched donor can be found in almost all patients, and we have the choice between related haploidentical or cord blood transplant. They give similar results. The main difference is the cost. One solution could be to ask cord blood banks to reduce the price for cord blood units in Africa in a pilot program for centers who already have an active program of sibling transplant. This program, Cord Blood for Africa, could demonstrate the use of cord blood transplant in low and medium income countries. So I think my collaborators in Eurocorn, Anadi, Fernanda, Chantal, and Monica in Paris, Barbara and Graziana in Monaco, Annalisa and Vanderson, my collaborators for a long time, and the other members, Marina Cavazzana, Ria Tauza, Karina Tosato, and Waid Boukouassi. I acknowledge Eurocord and Monacord, and this work has been possible by a grant attributed to Eurocord by the Monaco government and by the Monégasque Association of Cordon Vie. We are working, of course, with EBMT, the Pediatric Working Party, and the Cellular Therapy Immunobiology Working Party. We thank all the centers who provided clinical information. We have been doing studies with French Society of Transplant and Cellular Therapy, Dr. Marie Robin and Nicole Ross. We have a collaboration with Manchester University Professor Wynne, and with Anthony Nolan, Dr. Wynne. And we have very close collaboration with Africa, in Tanzania, at Stella Malangare, in Dodoma, Professor Makani, Professor Bukini, in Dar es Salaam, and in Senegal, Professor Ibrahim Adian, Saliou Diop, and in Du Dem Li. I thank you very much, and I say Asante Sana, which is in Swahili. Thank you, and merci.
Great. Eliane, I think, is joining us by Zoom. Oh, there you are. Hello.
Yeah, I'm here. Can you see me or hear?
Yes.
Yeah,
We can see you, and thank you so much for that great presentation. Please start asking questions and come up to the microphone, because that's the only way Eliane will be able to hear you, and just introduce yourself. Well, yeah, go ahead, Jesse.
Hi, Eliane. Nice to see you. I have a question for your transplant program. Is Tanzania so developed that they have platelets and blood available, which can be transfused? So do they do a lot of screenings for the blood products, but also maybe for a potential cord blood bank?
I have been several times in Tanzania, and I can tell you that the first time I came there several years ago, there was absolutely nothing. Everything had to be done really with scratch. And it's really with international collaboration and with the will of Julie Makani in Tanzania, and the help of the government and the collaboration with Europe, that they were able to achieve that. I think it's really a big achievement. Trying to develop transplant in other countries, and it's very, very difficult, because there is so much inequality in the care of these patients, and there is also some difficulty to find the financing and all the structure for the transplant. So I'm very proud that at the end, at least one of the center was open in Tanzania. As you have seen, the map of Africa is really empty, and I hope that this will be an example for other countries. But you know, it's politics. You need some stability, economic funding, and also you need a leader to really take it in action.
Okay, thank you. And then I have a question for the HLA types. So are there specific regions with specific HLA types, or do they have differences depending where in Africa you are?
We did this study. You know, it's very difficult, because Africa is the place where we have the ancestral haplotypes. Yeah. And this is much more diverse than the Caucasian haplotypes. There has been many migration there. And also, so when you look at black haplotypes, if you look at black people in America or in France, they are very different from the African population. Yeah. And so it's very diverse and very difficult. So to find a real HLA identical sibling in black population is very difficult. It's almost impossible. Okay. And because they are very different, for example, they don't have been, they have not Neanderthal. They have never met other populations before. So it was a reason why we will do the same study in Senegal and in Tanzania, compared to the studies that we have done, which were performed in transplant recipients in Europe. Okay. And the black patients we have in Europe are different from African American, because we have more recent immigrants who come directly from Africa.
Okay, thank you.
And did not have the mixture you have in the US. So it's interesting to see that. And if you look at sickle cell disease in India or in Africa, it will be different too.
Okay, thank you.
Great, thank you. Next question.
Excellent session.
This is so Eliane cannot see you, so.
No, I cannot see.
Hi,
Yeah, so
Ellen.
this is Juliet. Yeah.
So my questions are for Warren because I want to put him on the hot seat. Okay, Warren, a couple of questions. Firstly, and I think you know where I'm going with this, what do you think about the accuracy and potentially the sort of possibly even ethical questions associated with getting accurate social vulnerability histories from the patients, particularly underserved patients? And similarly, sort of stemming on to that same theme, what do you think the ethics are in terms of the accuracy or not of telling underserved patients that their adult unrelated donor searches are very poor?
Both excellent questions.
I am not the right person to answer that. I think it's for Karen or William, because in France we don't we are not allowed to give the race ethnicity in our registries, so we cannot say who is black and who is not.
Yeah, so just to review, in France, you're not allowed to collect data on race and ethnicity. Is that correct?
The same in Europe.
Okay. Warren, you want to go ahead?
Yeah,
this is something that you can do in the United States, but not in Europe.
Yeah,
Okay, Warren.
That's a really important limitation that you mentioned, Dr. Gluckman, because obviously race, ethnicity, ancestry data is critical not just to mitigate disparities, but even from a clinical perspective when triaging patients to alternative donor allografts. Now, with respect to Dr. Barker's questions related to the ethics of social determinants of health data collection and the accuracy, I mean, there are a number of issues that come up when collecting these very sensitive data. I mean, if you ask patients how much money they make, if you ask patients, their trust in the healthcare system, if they're having medical debt, whether they're in financial need, many kinds of concerns can come up. There can be concerns where patients are afraid that if they declare themselves as poor, to their oncologist or medical team, they will be worried that they'll be treated differently or negatively by the care team. I think these concerns are not reasons that we should avoid collecting these data. They need to be tackled head on. In the same way that it's relatively routine practice in the United States at most medical centers to collect race ethnicity data, and there might have been similar concerns related to that, I think it's so important to pair the collection of data that's sensitive with a detailed explanation as to the rationale as to why these questions are being asked and the importance of the data to improve the care not only of the patients but also of the population that's underserved. And so it's critically important when collecting these sensitive data to explain that.
Do you think that we need a script?
Yes, so staff training is paramount. And I give the example of it at Cornell. There's the We Ask Because We Care campaign. There's an article in New England Journal of Medicine Catalyst that details this campaign. And it was a campaign that included patient and staff education. There was support built into the IT programming so that patients who were uncomfortable at the first ask or who refused to answer, that was revisited later, again with the follow-up calls, et cetera, and programming to notify the care team that there were gaps in the available data to address. It was at all levels of the institution. There was buy-in from all levels of leadership to support data collection processing in this way and to provide the necessary resources to develop the training programming and to provide time for staff to get the training that was needed. And such efforts were important to collect race ethnicity data and would be similarly important to collect social determinants of health data. Now, as to your question related to the ethics of what to do when you have a patient that's unlikely to have donors available for them or that's likely to require the workup, the simultaneous requesting of CT processing for 10 or 20 donors for that patient to find just one that's willing to proceed with workup, et cetera. I think it's important that patients are told. I think that a lot of patients have no clue what happens behind the scenes and are not told that because of their unique situation, because of their ancestral makeup, et cetera, their genetic ancestry and so on, they're less likely to find, not only to have a matched donor in the pool of donors in the world, but to have one that steps up and is available and will show up if asked. And I think that's lost right now, and I think it's important that patients are counseled on this, and it's not something that transplant centers do routinely right now. Mm-hmm.
Yeah, I would just like to second that. I think it's very important that that's part of the conversation because it does impact maybe time to transplant and other things. I think the collection of race, ethnicity, and other social determinants of health data is very complex for all the reasons that you said. Patients may not want to divulge, and we're uncomfortable asking. I'll just put a plug in for the social vulnerability index because it's all done by zip codes and census tracts. So it's not accurate at the per patient data, but there's no questions to ask. And so that makes it a little bit easier to use.
I completely agree, and I'll add that the area-based measures of socioeconomic status may be of higher yield in some regions of the United States, for example, compared to other regions. In urban, dense centers, you may find them of lower value when you, for example, just as a particular example, in Manhattan, where MSK is based, of course, there's, neighborhoods where there's high-rises, penthouse apartments, and then right adjacent to that, there's people who are maybe multiple families living in a single small apartment, and so that's the same zip code with the same but then in a city that's more spread out, more rural, or in other parts of America, it can be higher yield, and then obviously in other countries it may not apply to. Mm-hmm.
I have another question if we've got time.
Sure.
This one's for Karen. So do you have any comments, and I don't know what the very hot off the pressed updated data is in this regard, but one of the major benefits of COVID was the ability to do telemed for the patients that are distant from the transplant center. That was really sort of such an incredibly sort of beneficial sort of development. And certainly at Sloan, I don't know what's happening around the country, is that our ability to do that is actually being dismantled. And that's a huge lost opportunity for the country. For example, let's say you have the transplant's done in New York, but the patient's in Connecticut. Well, the patient doesn't have to come 5 hours like back and forth, which would be a 10-hour trip. We just do telemed. But now, if there's no ability to bill, if the MD's in New York and the patient's at home, it's just like shut down. Any comments about that? Because there's big issues here.
Yeah, I would agree. So when the public health emergency ended in May, that did affect reimbursement, particularly for audio-only visits, but also for Zoom or other video visits with patients. And it is also complicated by, like you said, out of state. So if you're seeing a patient by Zoom from Connecticut and you're not licensed in Connecticut,
you're screwed.
Yes, exactly. So like I know our legal team has advised us not to do that. There are some, I know like we have neighboring states like in Virginia, West Virginia, it's easy to get a license there and do telehealth, but it's going to be more complicated. So I don't think we're making it easy on ourselves. I think this is we're partnering with local oncologists who may not have as much transplant, or definitely not going to have as much transplant experience, but figuring out a way to kind of partner there might help getting around some of these legal issues, but the ability to do telehealth and bill for it and not get in legal trouble is impaired now, I agree.
Do you think this is something that we should, as a community field, lobby the U.S. government about? I don't know what other
my guess it's not high on their list.
Sure, but it's nothing like sort of giving it the college try.
We can certainly do that. I don't know if anyone from the NMDP wants to comment on that, or if there's been any advocacy on that area. Not to put you on the spot. So I think it might be something to discuss in the transplant community to see what advocacy we could have in that area, because you're absolutely right. We have made it harder to do remote visiting.
It might be interesting to see what the solid organ transplanters are doing in this regard.
Yes, that's a good point. Other questions?
Hi, Emily Intranet. I'm from the National Cord Blood Program. I have a question about your very first slide about the discrepancy between what they first declare and what then your medical team assigned.
Yes.
Have you checked the actual HLA of these patients and how accurate both assignments were to the actual genetic background?
Yeah, it's a fantastic question. We explored the concept of ancestral genotyping of this population to add a third level to compare the race ethnicity versus BMT designated ancestry versus ancestral genotyping. The challenge was that it can be very expensive to do that, and it's not likely to become standard of care in the current year to ancestrally genotype all patients to determine their genetic heritage. We're using Ancestry as a surrogate here. There may be some data that you can ascertain with using HLA typing or others related to a patient's ancestry, but I don't think there's a validated way to do that. So it's a good question, and I think that it's definitely worth pursuing, just because it's really interesting to see how does the genetic history that we collect compare to the genetic ancestry data. Mm-hmm.
Thank you.
Eliane, it's Karen. I have a question for you on sickle cell. The cost of, let's say, non-transplant therapies for these patients is going up with newer treatments. Is there any studies like comparing the cost of transplant versus non-transplant therapies in countries that have a lot of financial concerns?
We have made a study in France, and we have seen that HLA identical sibling transplant is more cost efficient than transfusion and hydroxyurea. I think there is no doubt that if you look at the long-term cost of sickle cell disease with hydroxyurea and transfusion, the transplant is much more is better, especially if you transplant at early age. But you have to convince patients and you have to convince physicians. There is a lot of reluctancy concerning toxicity, sterility, and some long-term outcomes.
Great.
So if we look at just the cost, it's better to transplant as soon as you can.
Yeah, great. Thank you. Other questions? Okay, well, great. Well, thank you very much, Eliane, for joining us. I know it's nighttime there. Very much appreciated. And thank you, Warren, and thanks, everyone, for your attention.
Thank you. Bye-bye.
Thank you.